Hello, this is a lecture for General Medicine faculty of Azerbaijan Medical University. This is a third lecture for course 4. Today I will present lecture about preterm pregnancies. As you all know, a fetus spends 40 weeks growing and developing in the womb before birth. 40 weeks is considered full term. According to the World Health Organization, babies born before completing 37 weeks in the womb are defined as preterm or premature. Births happen before 37 weeks are called preterm or premature births. Premature babies can be perfectly healthy at birth and develop normally both in body and mind. Almost all will require some form of specialized supportive medical care after birth, and some will have continuing problems that will affect their growth and development. Spontaneous abortions is the most common complications of pregnancy and is defined as the passing of pregnancy less than 20 weeks of gestation. It implies the spontaneous lost embryo or fetus weighing less than 500 grams. Spontaneous abortions are commonly referred to as miscarriages and can occur any time during the first half of pregnancy. If it occurs before 12 weeks, we call it early pregnancy loss. If it occurs between 13 and 24 weeks, we call it late pregnancy loss. There are many reasons why spontaneous abortions occur, including genetic reasons such as fetal anomalies, infections, or metabolic and endocrine abnormalities. We divide all factors that cause spontaneous abortions in two places. It's usually maternal factors and fetal factors. Fetal factors are chromosomal abnormalities, other genetic abnormalities, hydropic degenerations, and multiply pregnancies. An abnormal karyotype is present in as many as 50% of spontaneous abortions occurring during the first trimester. The incidence decreased to 20–70% of second trimester losses and 5 to 10% of third trimester losses. The majority of chromosome abnormalities are trisomies, followed by polyploidy, usually in the form of triploidy. It's found approximately 20% of all miscarriages. Polyploidy conceptions typically result in embryonic gestations. And monosomy X is 80% of chromosomal abnormalities. Maternal factors. Maternal factors, it can be infections, organisms such as Toxoplasma gondii, herpes simplex virus, cytomegalovirus, Menial-Listeria monocytogenesis have been implicated in spontaneous abortion. Also, these agents, as well as Chlamydia trachomatis, have been found in women with first trimester losses. Other diseases like endocrine disorders such as hyperthyroidism, hyperprolactinemia, and poorly controlled diabetes mellitus. Also cardiovascular disorders such as hypertensive or renal disease, and autoimmune disorders such as synthetic lupus erythematosus and antiphospholipid syndrome are associated with spontaneous abortion. At less than 10 weeks, as the association between antiphospholipid syndrome and early pregnancy loss is controversial and less well established. Another factors for pregnancy losses is toxic factors. If mother uses angioplastic drugs, anesthetic gases, alcohol, or cocaine, this all can result in spontaneous abortion. The substances such as lead, ethylene oxide, or formaldehyde have also been associated with subsequent miscarriage. Traumas during pregnancy, direct traumas such as penetrating injury to the uterus, or indirect traumas such as surgical removal of an ovary containing the corpus luteum may result in spontaneous abortions. Amniocentesis or chorionic villus sampling are associated with high risk of pregnancy loss. Uterine factors and cervical factors may cause spontaneous abortions. Congenital anomalies that distort or reduce the size of the uterine cavities, such as incornuata or bicornuata or septate uterus, are associated with poor pregnancy outcomes. There is an increased risk of miscarriages as well as placenta abruption, into uterine growth restriction and preterm labor. In the picture, you can see, in the picture 16, you can see septate and double uterus with double cervix and a septative vagina. And in the picture 16.4b, you can see the hysterosalpingographies that showing the cornuata uterus. This is the uterine factors, uterine anomalies that can cause pregnancy losses. Also, the formation of scar tissue or synechia with the uterine cavity that leads to problems such as infertility or recurrent miscarriage is known as Asherman syndrome. This intrauterine adhesion or fibrosis are most commonly found after dilatation and curettage of the gravid uterus, either for spontaneous miscarriage, termination or treatment of postpartum hemorrhage. Diagnosis is often confirmed by hysterosalpingography or hysteroscopy. Of course, treatment is by resection of the adenosis of using hysteroscopy. Another maternal factor is abnormality of cervix. Usually it's cervical insufficiency. During this cervical insufficiency, it's painless cervical shortening or dilatation, the second or early third trimester up to 28 weeks, resulting in preterm birth. Congenital uterine abnormalities are associated with cervical insufficiency. About cervical insufficiency, I will give you more information a little bit later. Clinical types of abortion. First stage is threatened abortion, inventable abortion. Next stage is incomplete abortion, then complete abortion, missed and septic abortions. Threatened abortion. It is a clinical entity where the process of miscarriage has started but not progressed to a state from which recovery is impossible. Clinical presentations are vaginal bleeding, usually it's painless, may have abdominal cramps and backache. Cervix usually soft with closed internal os. size of uterus correspond to a period of amenorrhea. During the ultrasound examination, we can see well-formed, rounded gestational sac with fetus within it. If diagnosis of treating abortion made, pelvic rest is recommended. Prognosis is good when the bleeding resolves. Invasive abortion. Usually, women have painful vaginal bleeding from retroplacental side. Products of conception is about to be aborted, but not yet. It can progress to incomplete abortion, depend on whether or not all fetal and placental tissue have been expelled from the uterus. Clinical findings, it's usually vaginal bleeding, it's usually painful, associated with cramping, pain, and lower abdomen. During the examination, we will see that the size of the uterus is correspond to less than products of conception. Dilated cervical os. Management, its hospitalization, analgesics for control of pain. Incomplete abortion. Product of conception has aborted, but not completely. Usually, women have vaginal bleeding associated with colicky pain at lower abdomen. We can see signs of shock in pregnant women. During the examination, size of the uterus is smaller than it has to be. Cervical os is open, and ultrasound examination shows that reveal retained products of conception in the uterine cavity. Management, resuscitated bleeding is served, do blood group and cross-match, give analgesia for pain, evacuation of retained products of conception. Complete abortion. All the product of conception has completely aborted. It means the uterus is empty. clinical features, history of pain, and passages of product, followed by absence of pain. Sometimes it may happen minimal bleeding or not bleeding at all. During the examination of the woman, we will see that the size of the uterus is smaller than it has to be on this time of pregnancy. The closed cervical os, and during the ultrasound, we can see empty uterine cavity. The management is ultrasound to look for empty uterine cavity. But usually, if abortion happens before 14 and 16 weeks, it's still recommended to dilatation and curettage. But if abortion happens after 16 weeks, so only ultrasound, to see ultrasound in the ultrasound that uterine cavity is empty, it's enough for management of complete abortion. Missed abortion. When the embryo is or fetus is already died, but still remain in the uterine cavity for a period of time without any symptom of miscarriages. Usually women don't have any symptoms, but sometimes it may happen minimal vaginal bleeding. And also a woman can say that she feels that pregnancy symptoms are decreased. So if she had before vomiting, these little headaches, diseases, it's now she doesn't have any pregnancy symptoms. During the examination of pregnant women, we will see that the size of the uterus is smaller than it has to be. The cervical os is closed. During the uterine ultrasound examination, we can see crumpled gestational sac, revealed fetal pole, but no sign of activity. There will be no heartbeat of fetus. So we have to wait for spontaneous explosion, or we have to evacuate of retained products of conception. Ultrasound is helpful in the during the spontaneous abortions. Normally, intrauterine pregnancy, the sac is spherical and is a central place with the endometrium. At 5 and 6 weeks gestation, yolk sac will be present. In general, a gestational sac with a mean sac diameter of more than 8 millimeters should contain a yolk sac. Similarly, gestational sac with an mean sac diameter of 60 millimeters or more should also contain an embryo. This is the pictures of intrauterine pregnancy with gestational sac, yolk sac, and embryo. In certain abortion, ultrasound will reveal a normal gestational sac and viable embryo. However, a large or irregular sac, an eccentric fetal pole, and or a slow fetal heart rate carry a poor prognosis. Heart rate usually less than 85 beats a minute. In incomplete abortion, gestational sac usually is irregularly shaped. How you can incomplete abortion gestational sac is usually irregularly shaped, how you can see in the picture. Heterogeneous echogenic material representing retained products of conception is seen with the uterus. Endometrial sequence can be helpful in diagnosing an incomplete abortions. However, there is no consensus of cutoff value to distinguish complete miscarriages from incomplete miscarriages. Colored Doppler can be used to assess for flow with the tissue and can help differentiate retained products of conceptions that remain implanted within the uterus from tissue or blood that is in process of expulsion. Complete abortion. The diagnosis of complete abortion is also based on clinical findings. And on ultrasound, the endometrial lining, you can see here, endometrial lining appears seen, and no products of conceptions are visible within the cavity. Importantly, a complete abortion is only diagnosed with certainty if a previous intrauterine gestation was documented on ultrasound. Treatment of abortion. Successful management of spontaneous abortion depends on early diagnosis. Every patient should have a complete history taken and physical examination performed. Laboratory studies include complete blood count, blood type, and cervical culture to determine pathogenesis in case of infections. If diagnosis of threatened abortion is made, pelvic rest can be recommended. Also, it has been shown to prevent subsequent miscarriages. Prognosis is good when bleeding or other accompanying resolve. If diagnosis of missed or incomplete abortion is made, options include surgical, medical, or expectant management. The dilatation or curettage, was a good standard of treatment of incomplete abortion. But dilatation and curettage during the dilatation curettage is high risk of uterine perforations. But the advantages of dilatation and curettage include convenient timing and low rates of return products of conceptions. Some patients prefer medical treatments. Medical treatment usually use misoprostol, a drug that induce uterine contractions and expulsion of the products of conception. The risk of retained product is lower than with an expand management, and repeat doses of medication may be needed to complete the abortion. During the missed and incomplete abortion, dilatation and curettage or vacuum aspiration or medical treatment can be advised for the woman. So surgical uterine evacuation has long been the traditional approach for women presenting with early pregnancy loss. Women who present with hemorrhage, hemodynamic instability, or sign infection should be treated urgently with surgical uterine evacuation. Surgical evacuation also might be preferable in other situations, including presence of medical comorbidities such as anemia, bleeding disorders, or cardiovascular diseases. Many women prefer surgical evacuation, dilatation and curettage, to expand our medical treatment because it provides more immediate completion of the processes with less follow-up. The technique of dilatation and curettage and technique of vacuum aspiration you will learn and you will see during your practice classes. So if so we can treat abortion with dilatation or curettage or with medical medications. Medical management for early pregnancy loss can be considered in women without infection, without hemorrhage and severe anemia or bleeding disorders who want to shorten the time to complete expulsion but prefer to avoid surgical evacuation. Compared with expense management, medical management of early pregnancy loss decreases at the time to expulsion and increases the rate of complete expulsion without the need for surgical intervention. Misoprostol-based regimens have been extensively studied for medical management of early pregnancy loss. Most studies suggest that a large dose of misoprostol is more effective than small dose, and vaginal or sublingual administration is more effective than oral administration. Also, the sublingual route is associated more cases of diarrhea. So, medical management, medical treatment of misoprostol can be one of the treatment of spontaneous abortions. How to prevent spontaneous abortion? First of all, researchers show that taking 400 micrograms of folic acid daily might reduce the risk of birth defects and can lead to miscarriages. Of course, pregnant women have to follow a healthy lifestyle. And progesterone treatment. Progesterones are a group of hormones that bind to the progesterone receptors. They include both the maternal female sex hormone progesterone and synthetic forms. Medications that mimic the action of progesterone are known as progestational agents. Progesterone and progestational agents are known as progestins. Progestogens. Progesterone is secreted during early pregnancy from the ovary. It is an essential hormone for establishment and maintenance of pregnancy. Progesterones can be given to women with treated miscarriages orally as intramuscular injections or in the form of vaginal suppositories. Due to the wide range of doses, preparation, and types of progesterone used for treatment of threatened miscarriages, it is uncertain that is the best type, dose, and route of administration for treatment of threatened miscarriages. Progesterone includes secretory changes in the lining of the uterus, which are important for implantation of the fertilized ovum. In addition, it modulates the immune response of the mother to prevent rejection of the embryo through a protein called progesterone-inducing blocking factor, which is produced by lymphatics of the pregnant woman, white blood cells. And it enhances the uterine quiescence and suppresses uterine contractions. Also, low progesterone levels have been linked to increased risk of first trimester miscarriages. Septic abortion. Septic abortion is threatened, incomplete, or missed abortion, which the uterine content has been infected by virulent microorganisms. These infections may be confined to tissue adjacent to the uterus, parametric types, ovaries, or generalized hematogenic spread may ensue. Clinical features of septic abortions are rise of temperature of at least 38 degrees for 24 hours or more, chills, also severe abdominal pain or strong perineal pressure. Also, beginning miscarriage symptoms like heavy bleeding or cramping that suddenly stops and does not resume. Prolonged or heavy vaginal bleeding, foul-smelling vaginal discharge, backache or heavy back pressure. Causes of septic abortion. Septic abortion is often a complication of an infection of the upper genital tract by multiple strains of gram-positive or gram-negative bacteria. Septic abortion can occur when this bacteria enters the uterus or even when the natural vaginal flora becomes pathogenic. Also, sexually transmitted infections such as chlamydia may cause septic abortions. Clinical grading of septic abortions are grade 1, the infection is localized in the uterus. Grade 2, the infection spread beyond the uterus to parametrium types and ovaries or pelvic peritoneum. And grade 3, generalized peritonitis or endotoxic shock or jaundice or acute renal failure. The risk factors are the fetal membrane surrounding the fetus have ruptured, sometimes without being detected. The woman has a sexually transmitted infection such as chlamydia. An intrauterine device was left in place during the pregnancy. Tissue from fetus or placenta is left inside the uterus after miscarriage or elective abortion procedure. Unsafe abortion was made to end the pregnancy. Insertion of tools, chemicals, or soap into the uterus. Examination. First of all, complete blood count, high vaginal swab for culture and sensitivity, blood urea, creatine, and electrolyte, blood culture if septicemia is suspected, and of course, ultrasonography of pelvis and abdomen to detect intrauterine retained products of conception. X-ray of abdomen is in suspected cases of bowel injury. X-ray of chest for cases with pulmonary complications. Treatment of septic abortion. Crystalloids are used to restore circulation, and if necessary, blood transfusion is given. Also, monitoring of pulse, respiration, temperature, urinary output, and progress of the pain, tenderness, and mass in lower abdomen. Broad spectrum antibiotics given to the patient. It's usually a combination of ampicillin, gentamicin, and metronidazole, or cefotaxime along with metronidazole or clindamycin. Once infection is controlled, evacuation of the uterus is done. So once, if there's no response for treatment of for treatment of antibiotics and uterine evacuation, and generalized peritonitis with intra-abdominal abscess happen, it is indication, of course, for a laparotomy. Unembryonic pregnancy. Unembryonic pregnancy. It is a pregnancy in which the embryo fails to develop or is resorbed after loss of viability. On ultrasound, you can see the empty gestational sac without fetal pole. Clinical presentation is similar to that missed or threatened abortion. Mild pain bleeding may be present. However, we will see that cervix is closed and non-viable pregnancy is retained in the uterus. And of course, the treatment of unembryonic pregnancy, first of all, it is evacuation of retained products of conception, so dilatation and curettage is prescribed for women. Recurrent miscarriages. It is defined as 3 or more spontaneous abortions, affect 1% of women. Can be primary if woman has no successful pregnancy in her anamnesis, or can be secondary if woman had 1 or more births before recurrent miscarriages started. As the number of miscarriages increase, prevalence of maternal cause increase, and that of chromosomal abnormality decreases. Usually, recurrent miscarriages can happen in first and second trimester. In the first trimester, it's usually genetic errors. Genetic errors associated with recurrent pregnancy loss include maternal and paternal karyotype abnormalities and recurrent aneuploidy. When a karyotype abnormality is found, genetic counseling should be provided because the likelihood of subsequent healthy births depends on the chromosomes involved and type of rearrangement. In couples with normal karyotype, recurrent fetal aneuploidy can be a cause of miscarriage. The most common aneuploidies found are trisomies. Also, miscarriages caused by trisomies are usually random events. The frequency of such events increase with advancing maternal age. In the general reproductive population, however, trisomic miscarriage does not increase the risk of having similar outcome in the next pregnancy. Endocrine and metabolic errors. Possible endocrine causes of recurrent miscarriage include thyroid disorders, hyperprolactinemia, diabetes, and luteal phase defects. Immune factors. It's usually antiphospholipid syndrome. It is autosomal disorder defined by the presence of characteristic clinical features and phospholipid antibodies. The most common and serious complications of this disorder are venous and arterial thrombosis, in which the majority of thrombotic events are venous. Risk of thrombosis is significantly increased during pregnancy. Increased thrombotic potential in women with antiphospholipid syndrome is associated with recurrent pregnancy loss after 10 weeks gestation. Therapies usually with aspirin or without heparin reduce pregnancy losses. Also, uterine and cervical abnormalities, anatomic abnormalities in the second trimester Chronic material illness and unexplained reasons may cause current miscarriages. Cervical insufficiency or cervical incompetence. Inability of, it's one of the reasons of early pregnancy losses. It is inability of uterine cervix to retain a pregnancy in the second trimester in the absence of uterine contractions. Signs and symptoms. The diagnosis of cervical insufficiency is primarily based on a history of a previous mid-trimester pregnancy loss, which can present with the following: painless cervical dilatation and bulging fetal membranes upon representation in the second trimester of pregnancy. Preterm premature rupture of membranes, rapid delivery of preable infant, rare or absent uterine contractions. Risk factors: congenital disorders or collagen synthesis, previous canalization of the cervix, previous deep rupture of the cervix, usually with spontaneous or apparative labor, previous excessive or too last instrumental dilatation of cervical canal. Risk factor is Mullerian abnormalities such as bicornuate uterus or intrauterine septum. 2 or more history of miscarriages in the second trimesters. This is our risk factor of cervical incompetence. The diagnosis of cervical insufficiency is based on combinations of the following: clinical presentation, physical examination, and ultrasonographic findings. Most patients are asymptomatic, but some may present with any following of symptoms: pelvic pressure, also cramping, back pain, or increased vaginal discharge. Cervical length has a strong inverse correlation with the risk of spontaneous preterm birth, particularly in women with a history of preterm delivery. We can check the cervical length with transvaginal sonography, ultrasonography. Ultrasonographic symptoms suggestive of disease include cervical length less than 2.5 centimeters, dilatation of cervical canal, internal os diameter more than 20 millimeters at 14 weeks is suggested cervical insufficiency. Cervical insufficiency. Cervical cerclage is a mainstay of surgical treatment for cervical insufficiency and is reasonable in the following situation: history of second trimester pregnancy loss with painless cervical dilatation, prior cerclage placement of cervical insufficiency, history of spontaneous preterm birth, and a short cervical length prior to 24 weeks gestation. Painless cervical dilatation on physical examination in the second trimester. So, management of cervical insufficiency: cervical cerclage in which a stitch is placed at the cervicovaginal junction may benefit women with a history of cervical insufficiency or painless cervical dilatation in the second trimester on physical examination. Two most common transvaginal techniques are followed, McDonald and Sridhar technique. Preoperative evaluation for cervical cyclage should include the following: fetal ultrasound assessment for viability, gestational age, and any identifiable anomalies. Clinical evaluation to exclude active bleeding, preterm labor, and preterm rupture of membranes. Consideration of amniocentesis to rule out subclinical intraamniotic infections, particularly in women with a cervical dilatation at the time of presentation. The techniques of McDonald cerclage and Sridhar cerclage you will see and you will discuss in your practice classes. But you have to know that post-operative care should include consideration of the possible complications, including suture displacement, artificial rupture of membranes, and chorioamniotes. When cerclage is not recommended, it's not recommended cerclage placement for women with a short cervix who don't have a history of preterm delivery, as it has not been shown to be beneficial in this population. Moreover, cerclage is not recommended for twin pregnancies with a short cervix, as this has been associated with an increased risk of preterm birth. Certain lifestyle approaches, such as activity restriction, bed rest, and pelvic rest, have not been shown to be effective, and those should not be taken to treat cervical insufficiency. Risk factors are previous preterm delivery, being pregnant with twins, triplets, or more. Risk factors of cervical insufficiency are history or cervical surgery for abnormal pap smear if the amount of cervix removed is large. Abnormalities of uterus, uterine bleeding, especially in the second or third trimester. Use of certain recreational drugs such as cocaine, cigarette smoking, some infections, low pregnancy weight and low weight gain during pregnancy, excessive amniotic fluid, moderate to severe anemia early in pregnancy, a short interval between pregnancies, less than 12 to 18 months. It's been short intervals between delivers. Abnormal surgeries, abdominal surgeries during pregnancy can be the risk factor of cervical incompetence. So, according to the World Health Organization, babies born before completing 37 weeks in the womb are defined preterm or premature. Not all women who have preterm labor will deliver their baby early. Estimates rate are between 30 and 50% of women who develop preterm labor will go on to deliver their infant at term. If preterm labor leads to an early delivery, the premature newborn is at risk for problems related to incomplete development of its organ systems. This problem includes difficulty with breathing, staying warm, feeding, as well as injury to the eyes, intestines, and nervous system. So preterm birth is a major cause of newborn complication and death, Regular prenatal care can help to identify some, but not of all women at risk for preterm labor. If preterm labor occurs, various measures can be taken to both delay delivery and decrease the risk of newborn complications. The length of time a baby has spent in the womb, or more especially the number of completed weeks of pregnancy, is called gestational age. There is a subcategory of preterm births based on gestational age. Extremely preterm is less than 28 weeks, very preterm from 28 to 32 weeks, and moderate preterm, moderate to late preterm, 32 to 37 weeks. So it is late pregnancy losses, late pregnancy losses. In general, the earlier a baby is born, the younger his or her gestational age, the more problems she is likely have to, and less likely he or she is go on to develop normally. Mild premature refers to babies who are born between 33 and 36 completed with gestational age and or have a birth weight between 1.500 and 2.500 grams. Preterm labor. It is a process of coordinated uterine contractions leading to progressive cervical effacement and dilatation by which the fetus and placenta are expelled. So preterm is defined a labor occurring after 20 weeks, but before 37 weeks gestation. So preterm labor, it's between 20 and 37 weeks gestation. Also, there is no strict definition in the literature regarding the amount of uterine contraction required for preterm labor. There is consensus so that contraction need to be regular and frequent and at frequent intervals. Generally, more than 4 contractions per hour are needed to cause cervical change. The uterine contraction need to be painful to cause cervical change and may manifest themselves as abdominal tightening, lower back pain, or pelvic pressure. It is important to distinguish preterm labor from other similar clinical entities such as cervical incompetence and preterm uterine contraction, regular contraction in the absence of cervical change, because the treatment for this situation is different. Cervical incompetence may require cerclage placement, and preterm uterine contraction without cervical change is generally a self-limiting phenomenon that resolves spontaneously and requires no intervention. If ruptured membranes accompany preterm labor, these cases are classified as preterm rupture of membranes. Causes of preterm labor. It is spontaneous and iatrogenic causes. Iatrogenic causes may be in preterm cause of preterm labor. Usually, uterine bleeding happen during preterm labor. This condition, like placenta previa and placenta abruption, cause the vaginal bleeding and can trigger preterm labor. Stretching of uterus, having twins, triples, or more, or having polyhydramnions cause stretching of the uterus, which can lead to uterine contraction and preterm labor. Bacterial or inflammation caused by an infection can stimulate the products of substances in the uterus, placenta, or fetus that trigger uterine contractions. Physical or physiological stress, it's often happen in pregnant women. Severe stress may lead to release of hormones that cause uterine contractions and preterm labor, and a lot of other reasons that can cause preterm labor. Clinical findings, uterine contractions. It's uterine contractions, it's a regular uterine contractions at frequent intervals as documented by tachometer, or uterine palpation, generally more than 2 in 1/2 hour. Dilation and effacement of cervix and cervical change that is well affected and dilated on admission is considered diagnostic. Cervical length less than 10 per stele is also suggestive of cervical effacement. Other signs, vaginal discharge or passage mucus plug. It's all clinical findings in preterm labor. Monitoring the conditions of the fetus. First of all, gestational age must be 20 and 27 weeks, which must be calculated based on patient last menstruation period. Fetal weight determines the fetal size by ultrasonography. Representing part must be noted because abnormal presentation is more common in earlier stages of gestation. Fetal monitoring must be done. Tokogenomimetry should be performed to confirm presence and frequency of contractions. Physical examination should be performed to assess for cervical dilation, ruptured membrane, and vaginal bleeding and fever. Laboratory studies, complete blood count with differential, urine analysis, ultrasound, examination for fetal size, position, and placental location, amniocentesis, cervical and vaginal culture examinations, and a fetal fibronectin testing. I will give you later more information about fetal fibronectin testing. Another causes of preterm labor is the preterm rupture of membranes. The rupture of membranes before the onset of labor is considered premature. Premature rupture of membranes can be dangerous to the fetus and mother because the amniotic sac acts as protective barrier for fetus, shielding it from bacteria and viruses. Once the membrane have ruptured, the risk of infection increases the longer the fetus remains in the uterus. In addition, so much fluid may be lost that there is no cushion left around the umbilical cord, which can cause it to become compressed and cut off oxygen and blood to fetus. So premature rupture of membranes can occur at term before 37 weeks or earlier. This is referred to as premature rupture of membrane. It occurs It occurs in 1 in 10 pregnancies. Risk factors are decidual hemorrhage, a history of spontan preterm birth in a prior pregnancy, bacterial colonization of membrane, and invasive procedure like amniocentesis. At any stage, preterm rupture of membrane at any stage of pregnancy increases the risk of the following complications: infections of women and newborn, or both women and newborn, abnormal presentation of the fetus, and placental abruption. The diagnostic evaluation must be efficient and predictable, conducted to minimize the number of vaginal examinations and the risk of amniotes. So symptoms are the key to diagnosis. It's usually painless leakage of fluid from vagina. Due loss of fluid, fetal can easily feel through belly. Decreased uterine size. Also meconium presented in fluid. We can see it in ultrasound. Abdominal pain, usually women has hard abdominal pain. Fetal heart sound altered, cush of membrane, and absence of steady labor contractions. A most important step in accurate diagnosis is examination with sterile speculum. This examination helps to differentiate preterm rupture of membrane from hydorrhea gravidum, vaginite, increased vaginal secretion, or urinary incontinence. So 3 confirmatory findings associated with premature rupture of membranes: speculum vaginal examination of the cervix and vaginal cavity. First of all, pooling the collection of amniotic fluid in the posterior fornix. Nitraz test. A sterile cotton tip swab should be used to collect fluid from the posterior fornix and apply it to nitrazine paper, pH 7 to 7.25. Nitrazine test, the pH of the vaginal secretion is generally 4.5 to 6.0, whereas amniotic fluid usually has a pH of 7.1 between 7.3. False positive result may occur in the presence of blood or semen contamination, alkaline antiseptics, or bacterial vaginosis. Alternatively, false negative results may occur with prolonged leakage and minimal residual fluid. Furning fluid from the posterior fornix is placed on a slide and allowed to air dry. Amniotic fluid will form a fernicle pattern of crystallization. Prediction of preterm labor. Assessment of risk factors. Vaginal examinations to assess cervical status. Vaginal examination is digital. Usually, digital examination is a traditional method used to detect cervical maturation, but quantifying these changes is often difficult. And affection of fetal fibronectin or cervicovaginal secretion. What is fetal fibronectin test? Contractions of sufficient frequency and intensity to affect progressive effacement and dilatation of the cervix, and 24 between 37 weeks gestational are indicative of active preterm labor. If the diagnosis of preterm labor is suspected but not confirmed, it may be prudent to first obtain a vaginal fetal fibronectin sample before pelvic cervical examination. If the diagnosis remains in doubt after the exam, the fetal fibronectin specimen can be sent to lab for analysis. Fetal fibronectin is a protein produced during pregnancy. It is produced by cells at the border of amnion sac and the mother uterus, attaching the amnion sac to the uterine lining. The amniotic sac surrounds the developing fetus inside the mother uterus. For fetal fibronectin testing, a sample of fluid is collected from vagina or the opening to the uterus cervix. First, speculum is used to spread the walls of vagina to view the cervix. Next, a sterile swab is used to absorb fluid from the cervix or vagina. Fetal fibronectin should not be detectable in vaginal fluids between 22nd and 35 weeks of pregnancy. So, if fetal fibronectin is positive, a woman's risk of preterm delivery is increased over the next 14 days. If test negative means risk of giving birth in the next 2 weeks extremely low. So it's important to remember that in the 2nd and 35 weeks of pregnancy, fetal fibronectin should not be detectable in the vaginal fluids. Sonography of cervical length. 80 to 100% of women who deliver early have cervix less than 30 millimeters. 50% delivery rate within 1 week have cervix less than 50 milliliter or less. So that is why sonographic cervical length is important in the preterm versus to prognose the preterm labor. Bed rest. Bed rest may increase risk of maternal thromboembolism. Minimum bed rest can be advised during the initial evaluation of an episode of preterm labor to allow for close fetal and maternal monitoring. But it's not the main treatment to prevent preterm labors. Corticosteroids. The administration of corticosteroid to accelerate fetal lung maturity has become a standard care for treatment in 24 and 34 weeks of risk premature delivery within following 7 days. It has betamethasone 12 milligrams given every 24, a total 2 doses. Dexamethasone or dexamethasone 6 milligram intramuscular every 12 hours for a total of 4 doses. It has decreased the incidence of neonatal respiratory diseases and intraventricular hemorrhage and neonatal mortality. So we decrease all these incidents by giving corticosteroids. Use of corticosteroids so reduce neonatal morbidity and mortality, the risk of respiratory distress syndrome, necrotizing enterocolitis and intraventricular hemorrhage were all lower when either 12 milligram of betamethasone intramuscular was given twice in a 24-hour interval, or dexamethasone 6 milligram 12 hours was given for 4 doses. Steroids stimulate type 2 pneumocytes to produce surfactant in fetus. Steroids stimulate structural development of lungs of embryo fetus. It accelerates maturation of fetal intestines, affect myocardium. Repeat dose can be recommended to increase sepsis in the preterm rupture of membranes, restrict fetal body and brain growth, adrenal suspension, and etc. Tocolysis is if the patient is in the high-risk group of preterm birth. No conjugation to drugs, fetus currently healthy, short cervix in ultrasonography, or changing dilatation on cervical examination, tocolytic therapy may be initiated. When we're using tocolysis to treat preterm labor, it is important to keep the following goals in mind. The short-term goal is continue the pregnancy for 28 hours after steroid administration, after which the maximum effect of steroids can be achieved. The long-term goal is continue the pregnancy beyond 34 and 36 weeks, depending on institution, at which point fetal morbidity and mortality are dramatically reduced and tocolysis can be discontinued. The tocolytic therapy should be considered in the patient with cervical dilatation less than 5 centimeters, less than 4 centimeters. Successful tocolysis is generally considered fewer than 4 or 5 uterine contractions per hour without further cervical change. Beta-mimetic adrenergic agents act directly on beta receptors to relax the uterus. Their use is limited by dose-related cardiovascular side effects, including pulmonary edema, elevated systolic blood pressure, and reduced diastolic blood pressure, and both maternal and fetal tachycardia. Maternal medical contraindication to use of beta-adrenergic agents include cardiac disease, hyperthyroidism, uncontrolled hypertension, or pulmonary hypertension, asthma, required symptomatic drugs or corticosteroid for relief, uncontrolled diabetes, and chronic hepatic or renal disease. Because of side effects, beta-mimetic tocolysis is now limited on use, almost exclusive subcutaneous intermittent injection as method of temporizing and triaging patient before definitive therapy with other agents. Calcium channel blockers, usually it's, such as nifedipine, work as tocolytics by inhibiting calcium intrauterine smooth muscle and reduce uterine contractility. Prostaglandin synthetic inhibitors such as indomethacin have been shown to be as effective as ritodrine for tocolysis, but their use has been limited by potentially seriously fatal effects. Indomethacin works as tocolytic by inhibiting prostaglandin synthesis, an important mediator in uterine smooth muscle contractility. So here is shown the dose of calcium channel blockers, ginepral and indomethacin. Magnesium sulfate is ineffective at delaying birth or preventing preterm birth, and its use is associated with an increased mortality for infants. Antibiotics. Patients with preterm labor should be started antibiotics to prevent group beta streptococcus infections. If the patient grew to be streptococcus status positive, penicillin or ampicillin is used as first-line agents. Cefazolin, clindamycin, erythromycin can be used if patients are allergic to penicillin. Also, antibiotics used, antibacterial treatment during the PROM prolongs the late phase of labor, reduce the frequency of neonatal infections, reduce the frequency of infection in the mother, reduce the need for surfactant and oxygen therapy. During ultrasound examination, reduces the frequency of synthetic central nerve system pathogens found in newborns. So also preemies as premature babies can be perfectly healthy at birth and develop normally both in body and mind. Almost all will require some form of special supportive medical care after birth, and some will have continuing problems that will affect their growth and development. So premature babies often require medical support following birth. It is not necessarily that there is something wrong with the baby. In many cases, the problem is simply that he or she is in the wrong place. Instead of spending more time developing in his mother's womb, the baby is out in the world. In the womb, the fetus is protected from temperature changes and physical contact and is provided from in terms of nutrition and oxygen by the mother. The gestational period of the time the fetus spends in the womb is essential preparation for the outside world. It is the amount of time a fetus needs to develop the organs and mechanisms needed to deal with the challenges of living outside the womb. For these reasons, amount of time a baby has spent in the womb will largely determine the types and severities of problems that he has at birth and beyond. Additionally, the smaller the size of the baby at birth and the lower the birth weight, the more likely he or she is need to support and less likely he or she is developed normally, perhaps survive at all. That is why it is important to prevent premature preterm labors. One of the most important things a pregnant woman can do to prevent preterm labor is stop habits that can be harmful, such as smoking and use of recreational drugs. Women with a history of previous preterm birth at less than 37 weeks of pregnancy may be offered progesterone supplements, usually as injections, to prevent recurrent preterm births. Progesterone supplement is begin between 60 and 26 weeks of pregnancy and can be continued until 36 weeks. Women with no history of previous preterm birth who are found to have a short cervix on second trimester transvaginal ultrasound examination may be offered a daily vaginal progesterone supplement. Women with a history of previous preterm births who are found to have short cervix on a second trimester and transvaginal ultrasound examination may be offered placement of stitch around the cervix.